all of those participants, and I think we've got about 19 or so on that are on time. I am a stickler for being on time. So, what I'd like to do is welcome everybody to our Lynn Cancer Institute Physician Panel Series. Today's topic is understanding a rare cancer of bone and soft tissue, which is sarcoma. And we'll be learning from two of our amazing speakers today, both Dr. Harold Huss, a surgical oncologist, and Dr. Michael Casper, our radiation oncologist, that are both here at Lynn Cancer Institute. And we're so very fortunate to have both of these physicians working with our cancer patients, and they are experts that are deeply committed to improving the lives of the patients in our community. At Lynn Cancer Institute, we actually believe that education and awareness, prevention, screening, and early detection um, and a variety of treatment options, our latest technology, and the expertise of our staff are all extremely important. And we're going to be seeing that today. And the benefit of our multimodality method of treatment, all combined, really truly helps to save lives. I believe in the interest of time, we did send out our bio speakers so that you all should have received that by email. So I don't have to spend the next 20 minutes with all of their accolades introducing our doctors today. I'm going to invite you all to take notes, and if you have any questions, please do it in the Q&A or the chat. And at the end, we will manage those and let them answer the questions. They're not going to see or hear you, so you must put your questions into the chat box for us to see it. And at the conclusion of the two speakers' presentations, there will definitely be time for your questions to be answered. So we're very proud to welcome you to the Lynn Cancer Institute and introduce our first speaker, who is Dr. Harold Huss. So Dr. Huss, if you'd like to share your screen and get started.
One minute. Let's see.
At the very top, you'll see slideshow, I think.
Can you see my slide?
You are good to go.
Okay. Well, welcome everyone, ladies and gentlemen, today to our lecture with myself and Dr. Casper. Today we're going to talk about sarcoma, a malignancy that a lot of people don't know a lot about, but it is certainly a very interesting one, and one that we have a lot of patients here at Lynn Cancer Institute that go through this journey. The word sarcoma comes from the Greek word sarcoma, which means fleshy. I have no disclosures. Our outline today will be introducing sarcoma, talking about classification, presentation, differential diagnosis, histopathology, prognostic factors, risk factors, staging, screening, treatment, prognosis, and prevention and awareness. Sarcomas are a rare group of malignant tumors. They come from the mesenchymal origin, so meaning that they can come from muscle, called leiomyosarcoma. They can come from adipose tissue or fat tissue, called liposarcoma. They can come from fibrous tissue, called fibrosarcoma. They can come from blood vessels, called angiosarcoma, from bone, called osteosarcoma, cartilage, called chondrosarcoma, and many others. In adults, 80% of sarcomas come from the soft tissue and only 20% from bone. Most of these sarcomas arise de novo, meaning that they don't arise from a pre-existing benign lesion. As opposed to most cancers that you've heard of, sarcomas, there are 80 to 100 different histologic subtypes. Most cancers have only a few. How do we differentiate these 80 to 100? Well, there are many different ways, including morphologic pattern, immunohistochemistry, and molecular diagnostics. As I told you, it's too long of a list to list all the sarcomas, but here are just a list of a couple of them, like PEComa, adenosarcoma of the uterus, ovarian carcinosarcoma, Kaposi sarcoma, and giant cell tumor. In 2025, there are more than 2 million new cancer cases in the United States, with over 600,000 deaths. Sarcomas, only 1% of all adult cancers are sarcomas, and 21% of childhood cancers. There were over 17,000 cases of sarcoma in 2025 in the United States and over 7,000 deaths. The average age of diagnosis is 58 years old. Just for this lecture, there are two major groups of sarcoma, to simplify it. One is soft tissue and one is bone. Soft tissue comprises most of them, over 13,000 cases and 5,000 deaths. And primary bone sarcoma, as you can see, almost 4,000 cases. The best outcome from sarcoma is if you catch it at an early stage and if it's localized. When you have sarcoma that is already spread, it's usually incurable. Survival depends on many things, including subtype, location, size, grade, and stage. Bone sarcomas, most common bone sarcomas, osteosarcoma, chondrosarcoma, Ewing sarcoma, and chordoma. The most common soft tissue subtypes are liposarcoma, that's the most common, leiomyosarcoma, and malignant fibrous histiocytoma. So how do sarcomas present? So soft tissue sarcomas, it's usually a gradually enlarging, painless mass. Bone sarcomas, usually you have bone pain, especially at night, and sometimes swelling. There's also another group of sarcomas, which I left out, but GIST, or gastrointestinal stromal tumor, that these present with abdominal pain, bleeding, and feeling of fullness. Just for two slides, I wanted to touch on two other sarcomas that everybody asks about. One is called gastrointestinal stromal tumor, called GIST. Some people pronounce it GIST, but it's the most common mesenchymal tumor of the GI tract. There are over 5,000 GISTs a year, and it's the most common sarcoma. Most are sporadic. They come from the walls, the muscle cells in the walls of the bowel, esophagus, and stomach. And most of them are in the stomach, like this CAT scan in the right upper quadrant. You could see a tumor in the stomach right over here. And they can metastasize. They can metastasize to the liver, omentum, peritoneum. Majority of these are associated with an abnormal c-KIT pathway. And the treatment for GISTs are surgery versus a medicine called Gleevec, or sometimes both. The second sarcoma I wanted to talk about just for one slide is something called a desmoid tumor. Another name for a desmoid tumor is called aggressive fibromatosis. These are rare tumors that arise from fibroblast cells. They're locally aggressive and invasive, but they rarely spread. They definitely can cause pain and cause life-threatening problems. Most are sporadic, and some are associated with FAP, familial adenomatous polyposis coli, where patients have a lot of polyps due to an abnormal APC gene. When you have a desmoid in the abdomen, most of these patients have had abdominal surgery before. Up until year 2000, the treatment for desmoid tumor was surgery, but the problem is that many of these are extremely difficult to completely remove, and recurrence is very high. Even if you remove the entire thing, the recurrence is very high. And we found out that many of these tumors either will stay stable or they'll regress, go away. So now in 2026, the consensus is surgery is not the first line of treatment, but if a patient is asymptomatic with a desmoid tumor, it's actually watchful waiting. In 2023, the FDA approved a medication called nirogacestat, which is a medicine that's used for symptomatic desmoid tumors. Back to soft tissue sarcomas, the most common places we see them are in the thigh, buttock, and groin, but we also see them in the upper extremity, torso, retroperitoneum, which means in the back by the kidney and pancreas, and head and neck. Certain tumors, like an epithelioid sarcoma, most of the time we see on the finger and forearm, and small round cell tumors in the abdomen and pelvis. Sarcomas grow along tissue planes. They don't necessarily invade organs, but they compress surrounding tissues. If they spread, they usually spread hematogenously, meaning through the blood system, and most commonly they spread to the lung. 10% of people, when they are diagnosed with sarcoma, they're diagnosed with metastatic disease. And majority of these patients, once again, to the lungs. Patients who are increased risk for metastasis usually have high-grade tumors and tumors deep to the fascia. The sarcomas that most likely spread to the lungs are Ewing sarcoma, chondrosarcoma, and malignant peripheral nerve sheath tumors. Usually sarcomas do not spread to the lymph nodes, only 2.6%, but if they do, the patients have poor prognoses like synovial sarcoma, epithelioid, and clear cell sarcoma. Sarcomas do recur, even if you remove them, even if you remove the entire thing, but it depends on the location, depends on if you removed some of it, all of it, most of it, depends on if the patient had radiation, chemotherapy, and of course the histology. 25% of patients who have treatment for the sarcoma still have metastatic disease. And upwards of 50% of patients who have tumors that are 5 centimeters or greater, tumors that are deep to the fascia, and high-grade tumors also will have metastatic disease. And once again, the majority of patients that have metastatic sarcoma, it will go to the lung. However, of course, there are some exceptions like myxoid liposarcomas, which metastasize to the spine. And when you talk about the retroperitoneal sarcomas, the most common one, liposarcoma and leiomyosarcoma. Leiomyosarcoma will spread to the lung and liver, and liposarcoma usually recurs locally, meaning where you removed it. Not all bumps and lumps are sarcomas. So of course, there's a differential diagnosis. If somebody comes to your office with a lump or bump, it could be a lipoma, a benign fatty tumor. It could be an epidermal inclusion cyst. These are cysts with white cheesy stuff in it. It could be a schwannoma, which is a benign nerve sheath tumor, a lymphoma, metastatic disease, and many others as well. So how do you make a diagnosis? Well, first, there's usually delays with sarcomas, and the delays could be to the doctor, the delays could be to the patient. The patient may think that it's just a torn muscle or pulled muscle or a benign mass. A lot of MDs will call bumps and lumps automatically a lipoma, a benign fatty tumor. You need a good history and physical. But the concerning factors are masses that are greater than 5 centimeters, if they're painful, if they're increasing in size, if someone removes the mass and it comes back in the same exact place, and masses deep to the fascia. Tumor depth is the most sensitive marker for malignancy, followed by size and rapid growth. So what type of pictures do you order for sarcomas? If you have an extremity or a trunk sarcoma, we order an MRI. MRIs are excellent at looking at the extent of the tumor, the spatial orientation, and relation to surrounding structures. If you have a sarcoma in the abdomen, in an organ, or in the retroperitoneum, that's the area by the kidneys and pancreas, a CT is recommended. We usually do not order PET CTs for sarcomas because its ability to differentiate between benign tumors and low-grade sarcomas is not that great. And also, chest CTs are more sensitive than PET scans for looking at lung metastasis. So even if a PET scan is negative for lung mets, we cannot exclude pulmonary metastasis. And we're unlikely to change our treatment plan if we get a PET scan, because remember that there are not many patients that have extrapulmonary metastatic disease from sarcomas. And of course, there are exceptions where we do order PET scans, which, for instance, we order it to look at the response after neoadjuvant chemotherapy given before surgery. The NCCN guidelines recommends chest imaging for all new sarcomas. That can mean chest CT or chest X-ray. Chest X-rays are very accurate. But for abdominal or retroperitoneal sarcomas, we recommend CTs of the chest. The AJCC recommends chest CTs as well, especially for tumors that are over 5 centimeters, deep to fascia, or high-grade tumors. And for other tumors like myxoid liposarcoma, we order CT abdomen and pelvis. Cardiac angiosarcomas and alveolar sarcomas, we order MRI of the brain. And myxoid liposarcomas, we always order MRIs of the spine. After you order a picture, uh, then we biopsy the mass. And we want to biopsy to see if it's a sarcoma and, of course, what type of sarcoma it is. The most common biopsy route is a core biopsy. That's the most common because it's very accurate. The complication rate is very low, and it differentiates benign from malignant the majority of the biopsies. If you somehow get an incisional biopsy, that means taking a piece of the tumor, just a small piece. The same surgeon who took that incisional biopsy should perform the resection because you want to make sure that he or she knows where that incision is so it comes out with the tumor as well. If you're concerned about a recurrent tumor or recurrent sarcoma, then you can get an FNA, which is a smaller needle. Unplanned resections, called OOPS resections, that translates to someone, a surgeon who removes a mass because they thought that it was benign, and then all of a sudden, it comes back and it's a sarcoma, and they got most of it or almost all of it. Definitely increases the risk of metastatic disease. And in the literature, there are worse outcomes when you, quote unquote, have an oops resection. If you re-resect, meaning you remove a tumor twice in the same area, that definitely can affect the function of whatever extremity that you operate on. In the literature, it supports sending patients to a sarcoma center because there are improved outcomes. After you remove a tumor, you definitely should have it reviewed by a soft tissue expert pathologist for many reasons, including some sarcomas are associated with chromosomal translocations, and there are very complicated techniques that can test for these translocations that majority of pathologists don't have. A lot of sarcomas, we grade them with low grade, high grade, not all sarcomas, but well differentiated, moderately differentiated, poorly differentiated. So well differentiated tumor is a low grade tumor, poorly differentiated is a high grade tumor. And how do we know what grade they are? Either on the biopsy before the surgery or on the surgical specimen, meaning after you remove the tumor. Prognostic factors. When we look at prognostic factors, we can look at histologic grade, tumor size, pathologic stage, tumor depth, nodal status, metastatic disease, and others. Histologic grade, an undifferentiated pleomorphic sarcoma, which is a high-grade tumor, has a worse survival than a dedifferentiated liposarcoma, a tumor that is a low-grade tumor. Patients that have tumors that are less than 5 centimeters have a better survival than greater than 5 centimeters. We know that the risk of local recurrence and metastatic disease increases with increasing tumor size. And you can see from this paper over here that the frequency of distant metastatic disease in high-grade tumors goes up as you see with size. A greater than 20 centimeter tumor has an 83% chance of metastatic disease, as opposed to a tumor that's less than 2.5 centimeters has only a 6% chance of metastatic disease. Pathologic stage, when we look at stage, we look at the TNM system. T is the size, N is lymph nodes, M is metastatic disease. We also look at G. The G, or the grade, is a mixture of mitotic rate, necrosis, and differentiation. We put all that together and we come up with a stage 1 to 4. And of course, stage 4 is worse than stage 1. Tumor depth. Tumors that are deeper have a lower survival. Tumors that are spread to the lymph nodes or metastatic disease have a much lower survival as well. We have prognostic tools as well. We have nomograms. Here is a nomogram from Memorial Sloan Kettering Cancer Center, and there are multiple nomograms where they look at size, depth, site, histology, and age, and they come up with points. And then you come up with a number which depicts the patient's prognosis and survival. And it's a tool that you can show the patients, before surgery. There are nomograms here. This one is for retroperitoneal sarcoma, and there are even nomograms for specific sarcomas like a liposarcoma. So what are the risk factors for sarcomas? Risk factors for bone sarcomas: radiation, including radiation therapy, alkylating agents. These are specific types of chemotherapy, some genetic syndromes like Li-Fraumeni, RB1 gene mutations, and Paget's disease of bone. The risk factors for soft tissue sarcoma, which most are sporadic, are radiation, vinyl chloride, arsenic, thorotrast. Lymphedema is a well-known risk factor for angiosarcoma. There are some genetic syndromes as well, like FAP, neurofibromatosis. And we know that Kaposi sarcoma is caused by herpes virus. Staging, as I stated before, there's stage 1, 2, 3, and 4, and 1 is the earliest, and 4 is metastatic disease. How do you screen for sarcomas? The U.S. Preventative Service Task Force, as well as the American Cancer Society, does not recommend preventive screening. Why? We're not sure, or I'm not sure, but maybe because they're rare. But there are a whole bunch of genetic syndromes, for instance, neurofibromatosis, that may benefit from screening, for instance, to evaluate for neurofibromas. And if a patient has lymphedema, you want to evaluate for angiosarcoma. So how do you treat sarcomas? Well, there's surgery, there's radiation, neoadjuvant versus adjuvant, before surgery, after surgery. There's systemic therapies like chemotherapy, immunotherapy, targeted therapies, and observation as well. And of course, a combination of 1, 2, or 3 of these treatments. I just wanted to share a few pictures and demonstrate some sarcomas that we just perform surgery, some that we perform surgery and radiation, and some systemic therapy as well. So here's a picture of a right thigh, and here's a large tumor over here, a well-differentiated liposarcoma, and then you can see on the MRI, here's the tumor, and the specimen, which is a large liposarcoma or fatty tumor. Here's another well-differentiated liposarcoma, which encompasses most of the posterior aspect of the thigh over here, and you can see from the specimen a very large fatty tumor. And one more, once again, taking up almost the entire thigh, is a large, well-differentiated liposarcoma, all that we just operate on. Here's a picture of a CAT scan where you can see a very large retroperitoneal liposarcoma. This is next to the kidney, and this one we perform just surgery alone. Here's another very large liposarcoma in the retroperitoneum that encompasses almost the entire belly cavity, and you could see how large the specimen is, and this purple organ over here is the kidney, so you can see how large this is, about 40 centimeters. And once again, surgery alone. Here's a retroperitoneal leiomyosarcoma, a small tumor near the kidney over here. This is involving the renal or kidney vessels. And we remove this tumor with the kidney as well, but just surgery for this tumor. Here's a dermatofibrosarcoma protuberans. This is a tumor that's a sarcoma that doesn't spread, but has a very, very high chance of local recurrence coming back. So they need large margins. And once again, only surgery. Another dermatofibrosarcoma protuberans, where you can see in the buttock over here. And because these patients have such a high risk of local recurrence coming back in the same area, we take these tumors out with a very large margin. And here is the picture of plastics reconstruction. Here's a high-grade tumor, an undifferentiated pleomorphic sarcoma, as you can see over here in the leg. On the MRI, you can see it's pretty superficial. So because it's superficial and small in size, we just did surgery, and here's a full thickness skin graft to reconstruct the area. And these two pictures are gastric gysts or gastrointestinal stromal tumors from the stomach. As you can see in the CAT scan over here, coming off of the stomach, and this one as well. Here's the tumor, and here's the stomach. And these tumors, these gastric gysts, we also just perform surgery. Other tumors, like this right leg leiomyosarcoma, we give radiation first and then surgery. And as you can see, it's reconstructed over here with a skin graft. Here is a left leg pleomorphic dermal sarcoma that we just gave radiation, and radiation made the tumor disappear. Here's a very large leiomyosarcoma. This is before radiation. This, as you can see, it's erythematous or a little red. This is after radiation. And here's the CAT scan. You can see how large this tumor is, and then we performed surgery. Here's a myxofibrosarcoma of the back, and you can see in the scan over here. And this person had surgery first and then radiation, as opposed to this myxofibrosarcoma that had radiation in the same area, radiation and then surgery. And why the difference? Because this one was an oops resection and was removed or partially removed by another surgeon. So therefore, we did surgery first and then gave radiation. Here's a rhabdomyosarcoma of the knee, where we gave radiation and then surgery. Here's an undifferentiated pleomorphic sarcoma, which, as you can see, is a very large tumor, and this is a very high-grade tumor where we performed radiation first and then surgery. This is a dedifferentiated liposarcoma of the retroperitoneum, so involving, as you could see, the kidney over here, so radiation and then surgery. There is a rare synovial sarcoma, which is right here in the back, or on the PET scan you can see over here, involving multiple levels of the vertebral body. So this surgery, we removed the mass, and then as well as multiple levels of the vertebral body, and then gave radiation afterwards. Here's a myxofibrosarcoma of the thigh, and you can see in the scan over here. And this tumor, we gave radiation and then surgery. Here's an angiosarcoma of the scalp that we removed, and then radiation after the surgery, and here's the plastics reconstruction. Here's a rare histiocytic sarcoma of the back that we removed first and then gave radiation and then reconstructed it. Here's a myxofibrosarcoma of the scalp where we performed surgery and then radiation. And lastly, a Kaposi sarcoma where we just observed. And here are a few examples of systemic therapy. Here's an undifferentiated pleomorphic sarcoma of the leg. You can see in the MRI over here. And this tumor, we actually gave immunotherapy and radiation first, and then surgery, and then immunotherapy after the SARC-032 trial. And here's another patient. We gave the same SARC-032 trial, which is an elbow over here. And this is a large, high-grade pleomorphic liposarcoma. And this is after radiation and after immunotherapy. And this is after surgery. And here's a GIST. We showed earlier the smaller GIST, but here's a GIST, a gastrointestinal stromal tumor coming off the stomach with significant sarcomatosis. All this is tumor. So tumor spread all over the belly. We gave 9 months of Gleevec, a medication, and shrunk it to this size over here, and then we removed it. So how do you prevent sarcomas? July is Sarcoma Awareness Month. Well, I'm not sure about preventing sarcoma, but you have a lot of celebrities that are raising money and raising awareness for sarcomas. But to help with sarcomas, you definitely can have regular checkups with your PCP. minimize radiation exposure, and that translates also to CAT scans and MRIs. Avoid smoking, limit alcohol, balanced diet, be physically active, healthy weight, and sometimes genetic counseling. So in conclusion, sarcoma is a rare disease. There are 80 to 100 subtypes, as opposed to think about any other cancer. You have a few different subtypes. 80 to 100 subtypes is a lot. And if you see, feel a lump, mass, even if it's painless, bring it to the attention of your MD. The worst thing that they can say is that it feels like a benign lesion, because outcomes are much better if these lesions or these tumors are caught early. And there are many different treatment options, including surgery, radiation, chemotherapy, immunotherapy, and treatments in 2026 are definitely improving. And I will take questions after Dr. Casper's lecture.
Well, that was awesome. I learned so much, and I don't know about anybody else, but I probably have more questions than anybody. But thank you so, so much. That was so interesting and so thorough, and we appreciate the time and effort and the education, Dr. Huss. We are going to now pivot over to our medical director of radiation, Dr. Michael Casper, to share his screen and review the radiation side of all of this. And then once Dr. Casper has finished his presentation, I will help to monitor the Q&A portion of it. So whenever you'd like to share your screen, Dr. Casper, that would be great.
Should be coming up. All good? Do you see it?
Yeah, except I'm seeing your presentation view. So if you go up to where it says display settings on the top, right there, and click on that, and then you're going to do swap. And now we just see whatever. Yeah.
Is that good?
Yep.
Okay. Well, that was a fantastic presentation. Thank you, Dr. Huss. Especially all of those slides, that shows the depth and breadth of experience that he brings to the table. And I'm going to comment on that in a couple of minutes because that is so very, very important. And we're so lucky to have Dr. Huss, I've got to say. What I first want to talk about is our multimodality clinics. I usually start off these lectures. We're going to talk about radiotherapy specifically for adult sarcomas, but most of these cases come through our advanced cutaneous malignancies multimodality conference, which in most major centers, skin and sarcoma go together. Even though it's not a skin cancer in many cases, they're still considered along with the skin cancers in their multimodality clinics. And that is exactly how we do it. So I want to say that good medicine, especially top-notch cancer care, requires not only having the best technology, which we're very blessed due to the philanthropic support of our community here, but also hiring the best people and then providing them with the opportunity to work with other top individuals from other medical disciplines. And that's one of the features that sets LCI apart. That is our multimodality clinics. We have on-site specific cancer surgeons with great expertise like Dr. Huss, medical oncologists who are site-specific and subspecializing in disease sites, radiation oncologists as well who are specialists in their area and site-specific. And then we bring them together in these meetings and we have radiologists, pathologists, psychosocial experts, and dietitians who all meet with the patient at the same time. And then we get together to discuss the patient's case and come up with the best recommendations. And this is really state-of-the-art care. Patients aren't bouncing around from one physician to the next, waiting 6 weeks for an appointment. And meanwhile, the tumor's growing. And it's really important, especially for some high-grade sarcomas. So this is really the way it should be. And we're happy to be able to offer this at the Lynn Cancer Institute. And frankly, it's what we've been doing for probably over 20 years. So I want to just give a plug for our multimodality cancer clinics and just reiterate that this is the way cancer care should be delivered. I also want to say a bit about radiation in cancer, because although radiation is the single most utilized agent in oncology, it's frequently not well understood by patients and frankly, even many physicians. For this reason, it's sometimes underutilized despite being very high value and efficacious in the treatment of cancer. So it's also important to note, it's very important where you receive your treatment or where you receive your patient treatment. The radiation can make a big difference. Small changes in radiation delivery, such as use which dose to use, which technique, pre-op versus post-op, field size, expertise, the equipment that you have. All of these are true in all aspects of medicine, but it's particularly true in radiation and perhaps even more so in treatment of sarcomas. So I wanted to point that out. And along those lines, with sarcoma, we know that we get much better outcomes at high volume centers. It's really hard in cancer research to show improvements in overall survival. But here is a study, it dates back a few years, but it was pretty clear that the centers that had the most experience treating sarcomas did have much better outcomes, not only in overall survival, but in toxicity as well, in side effects and wound breakdown and other complications. So this is very telling. It's not something that's easy to demonstrate, but it's very clear that with sarcomas, experience really makes a difference. And that's why we're so happy to have Dr. Huss and have his experience. So he covered the statistics very well. I'm just going to give a brief overview again of a couple of highlights. As he mentioned, sarcomas arrive from mesenchymal tumor. So it's from, bones, cartilage, fat, other soft tissue. So it's not typical from like the squamous cells or the cells of the breast or the prostate, glandular cells that we see. So they're different than typical cancers that we most often see. So as he mentioned, they're fairly rare, less than 10,000 cases in the US annually. So again, as he mentioned, 1% of all US malignancies. Overall survival, generally in the 50 to 60% range for all stages and sites combined, but it's highly variable depending on the type of sarcoma, depending on when we find it, whether it's early or late, whether it's spread or not spread. Some sarcomas have excellent prognosis and can be easily excised and patient will be cured. Other patients will get surgery, radiation, and chemotherapy, and still we have a low likelihood of cure. So it's highly variable. And as he mentioned also, there are two broad categories: extremities and trunk lesions, which make up at least 50%, and then the retroperitoneal, which are about 35%. And most of the extremity and trunk lesions, the biggest risk is distant metastases. And the retroperitoneal challenge really for us is uncontrolled local disease. And there's several reasons for that. One, retroperitoneal tumors, I think, tend to get larger. You're not as likely to find them as early because they're hidden in the abdomen and pelvis. Extremity and trunk lesions, usually we can see the lumps and bumps and get them a little bit earlier. Retroperitoneal, some of our best treatments are more of a challenge. Certainly the surgery is more difficult, but we generally are not using as much radiation for retroperitoneal sarcomas because we can't be as aggressive. We can't use the doses of radiation that are necessary to have an impact on sarcomas because of a lot of the adjacent structures. The toxicity is greater because of kidneys and bowel and other structures in the abdomen and pelvis. So we're less likely to use radiation. Now, that may change somewhat with the advent of proton therapy because we can better target and give less surrounding tissues radiation with proton therapy. So that's an area that is being ferreted out at this point. Dr. Huss did a great section on presentation, but again, this is kind of what it looks like. This is an extremity, and this big white area here is a tumor in an extremity. And the most common presentation is a painless mass. Although if you have a mass with pain, that's very worrisome and a poor prognostic factor. Most of the time, these show up just like, hey, I've had this bump for a long time and now it's growing. What do you think? So this is the most common presentation. So a way back, this is an ancient slide, right, from 1982. But I remember during my training, it was still a little bit controversial. There was a big paradigm shift in the curative management. The primary management was amputation. I think most people my age or older remember the Kennedy child who had an amputation. I think it was Teddy Kennedy Jr. had an amputation. Actually, that's not right. He saved his leg because he was one of the first people in this trial. The standard at that time was amputation, and he participated in this trial and was able to save his leg. And the paradigm shift, the change in management was adding radiation to surgery, and instead of doing amputation, just trying to take out the mass. And it was shown that if you added radiation to a wide excision as opposed to an amputation, you could get the same, essentially the same results. And that was a huge, huge change. And you can imagine all of the limbs that were saved because of that. And that was really the introduction of radiation as a staple for treatment in sarcomas. As time went on, we started thinking in not just sarcomas, but in other areas, there are some advantages to giving preoperative radiation. That's radiation before surgery as opposed to after surgery. Usually we do surgery and we see whether or not we think that radiation will be beneficial. We look at the pathology, we look at the margins, we look at other features, we look at the patient, and we see how likely they are to heal up well and tolerate the radiation, and then we make the change. But there were certain advantages that we knew existed, and we wanted to evaluate those. For instance, we could give faster treatments, so because a lower radiation dose is required prior to surgery than after surgery. Well, why would that be? One of the reasons is there's a better biological effect due to improved tissue oxygenation. We know that radiation is more effective in tissues that have a lot of oxygen. And after surgery, a lot of the blood vessels are cut and there's more fibrosis and stiffness, and you're less likely to get as much oxygenation. And cancer cells can better hide and evade the radiation and be less sensitive to the radiation. So we know that if we can treat in an oxygenated, excised area, that radiation is more likely to be effective for the same cells. We also know that we can use smaller fields since the tissues have not been disturbed. Tissues haven't been moved around. There's no contamination by cells that may be in the surgical bed. So we can treat a smaller field with smaller margins. And this can help the possibility of a complete resection. An RO resection means a complete resection where all of the tumor is resected as opposed to leaving a few cells behind at the margin. And we also know that there's less long-term toxicity due to a lower radiation dose and a smaller field. The side effects of radiation are directly related to the radiation dose, the total dose, and the size of the tissue irradiated. Usually what we see in sarcomas, especially with higher doses, is fibrosis, a very stiffened and sometimes discolored area of skin. And that's a fairly common side effect. So there were a number of trials. We don't have to get too far into the weeds with this, but there were very good trials from major journals, the Lancet and the Red Journal in Radiation Oncology. And these really well established that preoperative radiation was as good or better than postoperative radiation. Some of the earliest trials showed some healing issues or postoperative issues, wounds breaking down. But I think many surgeons learned how to avoid that. And many subsequent trials have shown almost no difference in postoperative changes or postoperative outcomes. But by and large, when we have the option, when we know that radiation is probably going to be part of the treatment, it's usually better to give the radiation before rather than after. Again, here's the a large national oncology database study that showed that here the overall survival, and as I mentioned earlier, overall survival is really, really hard to show. And this almost showed an advantage. It was almost for significance, we need, the null set or the chances of it not being true have to be 5 out of 100. Here it was 0.07, so 7 out of 100. So this wouldn't be considered significant, even though there's a huge trend and a likelihood that the overall survival was better with pre-op versus post-op. But all of the other things that were evaluated in these studies did show that radiation was pretty significant. So the overall survival was 65 versus 60. Again, not quite significant, but certainly a signal and a strong trend towards an improvement. The cause-specific survival was significant. The metastatic, disease-free metastatic survival was, and other metrics were also significant. I wanted to say a word about proton beam therapy since we've opened up our proton center, and that's going to be a very important aspect of sarcoma as well as other cancer treatment. Currently, we don't have strong data supporting proton use for sarcomas, and that could be because this is so rare, and we've been focused on other more common sites. But there are certain areas where it's very clear that protons would be advantageous, such as in the abdomen, the thorax, head and neck, when we're trying to really limit the dose to adjacent structures, especially when we have to treat with high doses. So these are areas where protons would likely be approved by the insurance companies and the Medicare. We wouldn't have to fight really to get approval because there's not great data. But this is a rendering here. This picture is a rendering of the Proteus One. This is our machine that we have here now at the Lynn Cancer Institute. It's really one of the latest and greatest proton therapy delivery devices out there. It's got all the bells and whistles, and it's able to provide the most precise, effective, and safe radiation available really anywhere in the world. This is the most common machine now being delivered, and we've got it for proton therapy. And proton therapies are rare. This is like one of 50 centers in the country that have protons. But if they're putting a new one in anywhere in the world, this is the Cadillac version.
Dr. Casper, your little Varian screen is up because for ARIA. I don't know if you can slide it a little bit so people could, I think we missed
Yeah, I'm
the picture.
sorry.
No, it's okay.
Yeah.
I know it happens all the time. I don't know if you can just slide it even over
Yep.
out of the way and then we can all,
There we
yep,
go.
thank you.
So again, Dr. Huss mentioned some words about adjuvant chemotherapy data. It's been hard to show great advances in or great efficacy for chemotherapy. We've been working for a long time, but still, I think some of the most aggressive chemotherapy regimens we use are using the same chemotherapy with adriamycin and ifosfamide. The clinical trials now that are used are often using immunotherapy. There are some sarcomas, however, where systemic therapy is very much accepted and indicated, such as the GIST tumors, the gastrointestinal stromal tumors that Dr. Huss talked about, and we use agents like Gleevec. So there are some cases where systemic therapy is indicated, but for the most part, for most of these difficult sarcomas, it's still investigational. Although for the most aggressive ones, we are certainly using chemotherapy and trying to get patients on clinical trials. And I think that's the end of it. I'm happy to take any questions along with Dr. Huss.
You're muted, Darcy.
I want to say thank you so much to both of you. I've spent most of my career doing only breast, so this was a great information for me as well. So thank you both very much. And as I'm waiting for people to ask questions, I'm going to start because I have a bunch. Dr. Huss, you mentioned something about the oops resection. So you have something, you go to see a doctor, maybe you get imaged. And so how what, like, I'm assuming I know the answer, but what's the best way to hopefully prevent an oops resection? Is it just a surgeon selection, or what do we do to make sure that we avoid an oops resection?
Well, that's an excellent question. And depending on where you go and who you go to, but if you have any concern, if the doctor or the patient yourself has any concern that this may be a sarcoma, then you need to biopsy it. And whether that's an IR, interventional radiology guided biopsy, or even a small biopsy in the clinic, as opposed to doing an excisional biopsy, meaning trying to remove it and then finding out that it's a sarcoma. Because as we just learned from both of these lectures, that depending on what it is, if it is a sarcoma, you may need radiation first, you may need chemotherapy first. And when somebody removes it, now you just removed the NCCN guidelines of how you're supposed to remove that specific sarcoma. So if you do have a concern, the answer is not to just remove it, but to biopsy it and find out what it is before tackling it.
Got it. And it makes a good point. And I think to Dr. Casper's point, the combined modality of having multiple specialists is really, really helpful so that you're really getting a broad strokes of a team approach looking at some of these things. Some of the pictures you showed, which at first I was afraid to look at, but actually they were really quite interesting. I couldn't get over how large some of these tumors got. And so, I mean, I know you say some have pain, some don't have pain, but as a layperson or as a person that might have something in their body, how do you know when you're supposed to be running to a doctor or not?
Well, as Dr. Casper was talking about before, with the retroperitoneal tumors, they can grow quite large before you notice it. A lot of people think that they're gaining weight. Um, but and these tumors, could grow very, very, very large before you notice it. A lot of people think that they have stomach pains, but of course, a good PCP will take the patient's concerns, won't take it lightly, and investigate. But still, even with saying that, there are a lot of patients that come and they're extremely large. And when they're that large, they press on many organs. And as Dr. Casper said before, uh, the surgeries are very, very difficult because these tumors are quote unquote touching or abutting many, many different organs. And you can't just take out every organ. Similarly with radiation, if you're going to radiate the whole tumor, you may hit so many different adjacent organs. So with retroperitoneal sarcomas, it's nice if you catch them smaller than larger.
For sure. I have a question in the chat box here, and it says, once a sarcoma is removed, what are the chances of it to come back? And I think you guys both mentioned that recurrence is likely, either in the same area or a different area. And is there any type of genetic testing that you can do?
Well, that depends on many, many different things. It depends on what type of tumor it is. It depends on how the surgeon removed it, what type of margins, how do the margins look. It depends on if the patient had radiation, had chemotherapy. Of course, like I said, what subtype it is of sarcoma. So I think that's a very difficult question to answer, and that's why you need a sarcoma center with all the experts to figure out the best treatment for the sarcoma, which will hopefully give you the least risk of recurrence. But unfortunately, many, many sarcomas have a high recurrence rate locally, coming back in the same area. And even if the surgeon did a great job in taking out the entire tumor, good margins, but still, especially with high-grade sarcomas, they can metastasize, especially to the lungs. And that's why, of course, we follow sarcoma patients for the rest of their lives.
Yeah, absolutely. I've gotten lots of great presentations and thank yous. I don't see any more questions in the chat box. I do want to say thank you to both of you. As I mentioned, I learned a ton. I found this so interesting. We do our best to record these lectures. And so, as in the past, what we can do is we'll hopefully be able to set it up on a YouTube. You can reach out to Lee Jensen, or even me or Jan Dimtro, and we can see about emailing it to you. Anybody that signed up and registered, you will get an evaluation. This is how we know what interested you and what else we can do in the future to have more interesting conversations. These Zoom and Connects have been the best thing that came out of COVID, because we are now able to reach such a larger number of people, and just the access is amazing. We're going to take the month of August off from education so we can all have a little summer break, and we'll be rejoining in September because we have a couple of topics coming up. So again, I just want to say thank you to both Dr. Huss and Dr. Casper for your time, for the amount of energy you put into these really educational presentations. And I hope everybody has a great afternoon and weekend.
Thank you so much.
Thanks,
Thank you.
everybody.